Good afternoon, everybody. So welcome to Grand Rounds. For those who don't know me, I'm Alfred Berger. I'm the Senior Associate Program Director here in the residency program at Sinai Beth, Israel. And it's my pleasure to get to introduce someone I've known for a long time. I really respect, is one of probably, I think, the most thoughtful and brightest people I know and have had the opportunity to work with over a few years. Dr. Noam Harel, who is a neurologist up at the VA, the James Peter VA Center here in the Bronx, New York. I first got to meet Dr. Harel when we started our internships together many, many years ago. He asked me not to mention it. So, but a long time ago, we did our internships together at Pennsylvania Hospital in Philadelphia. Dr. Harel joined Pennsylvania Hospital after doing his undergraduate, his MD, and his PhD, all at the University of Pennsylvania, where he started to form a lot of his interests in spinal cord injury and spinal regeneration. After completing internship, he moved on to train in neurology here at Columbia, New York City. After which he went to be a fellow and then a junior attending up at Yale University and at the New Haven VA. And then he returned to New York a few years ago to join the VA and the Icahn School of Medicine and has been here since. A few noted things about Dr. Harel. He is currently the chair of the American Academy of Neurology Spine Section. He is on the board of directors for the American Society of Neurorehabilitation. He's on the editorial board of the journal Neurology, which for those who don't know in our audience is the premier journal in neurology and neurologic fields, sort of like the equivalent of JAMA in neurology, the way we view JAMA. So he continues to run his own lab and it does work in spinal cord injury and ALS. The lab is located up in the Bronx, VA. He uses targeted physical exercises, electrical stimulation, ischemic conditioning, and other methods to reactivate weakened nerve circuits. And his work is currently, or has been in the past, funded by the VA, NIH, New York State, and the Craig Nelson Foundation. He's currently an associate professor in the departments of neurology and rehabilitation and human performance at the Icahn School of Medicine. And I'm really excited to hear about his research, which I've heard about sparingly over the years. But I'm really excited to hear about it today. And with that, I'm going to turn it over to Dr. Harel to tell us everything.
Thank you, Alfred. And thank you, Hayato, for helping set this up. And nice use of the word sparingly, because that's kind of the crux of what we work on here is spared connections. It's been a while since I've been down at Beth Israel. It's unfortunate we can't do things in person yet, but hopefully next time. So yes, we'll talk about our approach to trying to improve recovery by activating spared connections after spinal cord injury. Okay, so Alfred kind of just mentioned sources of funding. I don't have any conflicts of interest. We definitely will be discussing investigational interventions. And really just to outline what we'll talk about today. First, spinal cord injury, those of us that don't have an injury, we think of a wheelchair, but it means a lot more than that. We'll talk about that. And if there's really one take-home point I'd like to get through, it's most spinal cord injuries are incomplete. Most injuries do not completely transect the cord, and there is tissue left to work with after spinal cord injuries. So we'll talk about that. And then because of that incompleteness, we try to take an approach to improve recovery by rerouting signals through spare tissue, not necessarily regenerating. It's still a little far off. And the way to improve this rerouting process is to increase neuroplasticity. And the way to increase neuroplasticity is to activate the nervous system. And we take a bunch of approaches to that. We'll talk mostly today about electrical and magnetic stimulation. And Yu-Kwang Wu, who's a young investigator in our group, is taking an approach of remote ischemic conditioning, which I think many of you might have heard of. And Linda Murray, another young investigator in our group, is taking the approach of repurposing FDA-approved drugs to try to stimulate plasticity. And we really have a great team of current and former coordinators, none of which is, none of this would be possible without them. So I'll be mentioning them along the way. Okay, so again, if you do not have a spinal cord injury, when you think about spinal cord injury, you're thinking of the wheelchair. You're thinking about your priority would be to walk again. And that is an important priority. But if you actually ask people who are in wheelchairs what their priorities for recovery are, walking is usually 4th or 5th place. Okay, so if you have paralyzed hands, that's by far the #1 choice. So if you have a cervical injury, you want to regain hand function. And no matter where your injury is, you tend to have adverse impact on sexual function, bowel and bladder function, and even balance while you're sitting. These are priorities over walking for people that have these problems. Okay, so we have to keep that in mind. And this is not just a neurological disease. This is not just a rehab condition. This is a medical condition. There are numerous medical consequences after spinal cord injury, shown here. And we'll talk about some of them. But the point is, where I work is actually called the National Center for the Medical Consequences of Spinal Cord Injury. And it was founded here by Bill Bauman. He's an endocrinologist. So you guys kind of run the show, okay? They're in medicine. Bill Bauman is an endocrinologist, and he started the center to study all the numerous medical consequences of SCI. Okay. So I'm a neurologist. I don't carry a stethoscope anymore. Stopped. Okay, I carry a reflex hammer, but I believe this is a heart. Okay, and this is a big LAD infarct. And I don't think Alfred would teach you guys to throw in the towel and walk away just because you've lost a lot of tissue here. There's definitely tissue left to work with after a large MI. Someday, very soon, we'll be able to regenerate this tissue, but it's not quite here yet. But we're able to help people survive and kind of make a recovery after even some large MIs, if I'm not mistaken. So the point of this is the same applies in spinal cord injury. There usually is tissue left to work with. Okay, and I will try to hammer that point home in the next slide as well. Okay, so think of it just like a large MI. We can still mediate some recovery with the remaining tissue. Okay, and again, I'll say most spinal cord injuries are incomplete. Okay, and there's two ways to show that, several ways to show that. One is only about half of people who suffer a spinal cord injury have complete paralysis below the injury. The other half actually do retain some movement in their muscles below the injury. So automatically, off the bat, they're motor incomplete. And even those who have complete paralysis usually do retain some intact circuits or intact nervous tissue getting through the injury. And you can see that in multiple ways. There's a lot of autopsy studies back in the day on people who had died after spinal cord injury showing they still had intact circuits. Now we can do this non-invasively during life using diffusion tensor imaging, MRI. And basically that shows intact axons in blue. And you see here, very severe spinal cord injury, clinically complete, but there are intact axons getting through the injury. And we won't go through the details here, but we can also measure this neurophysiologically. You can measure electrical signals getting through the spinal cord even after severe injury. This electrical activity may not be enough to mediate volitional activity, but it is enough to mediate spasms, okay? So spasticity, all sorts of spasms below the level of injury can be very annoying to patients, okay? But the one little silver lining there is that usually spasticity or different types of spasms below the injury indicate there is some electrical connection getting through the injury. We don't know how to volitionally control it yet, but that's our goal. Okay, so there's a lot of evidence that even people who cannot move below the injury have retained circuits getting through the injury. Okay, we would love to regenerate. Oh, and please interrupt at any time. Let me pull up the chat. Okay. Anyway, we would love to regenerate the lost tissue after spinal cord injury. We're not there yet. And I can give a whole other set of slides showing all the barriers to not only regenerating this tissue, but reintegrating it back into a working nervous system. What we really want to focus on today is not necessarily regenerating all that tissue, it's rerouting signals through the spare tissue. Okay, so we call that recovery through rerouting, not regeneration. And to mediate that process, we want to activate the nervous system, and that triggers neuroplasticity, which I'm sure is a term we've all heard of. So we take a lot of different approaches to increasing neuroplasticity. And again, like I said, we're going to talk mostly about electrical and magnetic stimulation today, but you can also use various types of exercises, ischemia, and drugs. Okay. So like I said, we're going to talk about electromagnetic stimulation. Now here's where I always get uneasy because there are so many variables to consider when you want to stimulate the nervous system. Where in the nervous system you're going to stimulate? What type of pattern is it going to be? And it's not just an either or. Each of these three categories has numerous or really infinite number of patterns of stimulation you could apply within it. So there's all sorts of factors we can control with stimulation. And then there's all sorts of factors we cannot control usually with the participant. Everyone has a different injury level. Everyone has a different pattern of their injury severity and age. How they slept the night before, the week before may affect their response to stimulation. So all of these factors kind of mix together in an infinite number of combinations, and it makes it really hard and really slow to do research and trying to find the best way to stimulate the nervous system. And the bottom line is we need to individualize treatment when you're talking about neurostimulation to try to improve recovery. I think the field is really reaching a pretty strong consensus on that. There's not going to be a one-size-fits-all type of stimulation. We need to individualize treatment. So I have a question. These are dilemmas that we face in neurorehabilitation research. One dilemma is we live in the EBM, the evidence-based medicine world. How are we going to get formal approval from FDA, from insurance companies for technology that's highly individualized? Our EBM world is not really set up for that. How are we even going to conduct blinded RCTs when it's pretty much impossible to blind someone zapping you? You can feel it, or different types of physical exercise. You're not going to be blind to that therapy. And this is a major problem. So does anyone know the answer out there? Maybe Dr. Berger Sr. knows the answer. I'm open to suggestions because we don't know the answers to these. These are difficult questions. Right, so keep that in mind. Okay, so want to talk first about one type of spinal cord stimulation called epidural spinal cord stimulation. And I bet most of you have heard of this in one form or another because it is in the news a fair amount, okay? So these are stimulators that are placed over the dorsal surface of the meninges of the spinal cord. So it's epidural. It's not on the spinal cord directly, but it's very close to it. And these have been used for more than 50 years. And they're used to treat pain, okay? They're also known as dorsal column stimulators in some pockets. So dorsal column stimulators, and the dorsal columns, if you recall, what you learned in med school, those are sensory tracts. Okay, so these implants are activating large fiber sensory afferent circuits. And they're used, at least originally, to treat pain. Okay, and it works in theory via the gate control theory. And it's why when you hurt your arm, you'll try to rub it or scratch it, and you're basically replacing small fiber, nociceptive signals with large fiber tactile stimuli. Okay, so you're trying to replace a noxious circuit with a different circuit, or a large fiber circuit. That would be the casual way to explain gate control theory. And it's also why a lion will lick its paw after it steps on a thorn, for example. Okay, so this is a sensory activating implant. point is, activating this nervous system is critical for controlling movement, okay? If we were having this talk in person today, hopefully there'd be cookies or some form of dessert available. And I don't think any of us could, some of us at least, cannot control ourselves when we see that. So our hand starts reaching based on that visual sensation. But seriously, what I really wanted to point out was the hand here. This is called pre-shaping. You're clearly not consciously thinking of getting your hand ready to grab a cookie or an object, whatever it is. But your nervous system has certain expectations. It kind of expects the weight and the size and the shape of the object it's about to grasp, and your hand starts pre-shaping in that form. This is a whole sensory feedback, motor feed forward loop, okay? Very important. It's very evolutionarily conserved, okay? And cats, I love cats, but they also happen to be the subject of a lot of research in this field, okay? So it's a very evolutionarily conserved mechanism. And again, it's all about muscle spindles, Golgi tendon organs. We're not going to go through that again today, but the point is, when we're walking, we don't have to think about it. All we have to do is get certain sensory stimuli back from our muscles and tendons in the legs, the Golgi tendon organs. They go up to the spinal cord and synapse on a bunch of interneurons, and they take over this rhythmic flexion and extension of one leg and then the other to swing and stand in time while you're walking or running. This is all sensory feedback driving motor output. So we can be proud here in New York. These are neurosurgeons in the 70s and the 80s that started noticing their patients who had these dorsal column stimulators, these epidural spinal cord stimulators for pain, started having improved motor function, whether they had multiple sclerosis. This paper is a case series on, I mean, it's the largest case series in this field by far. People with cerebral palsy, certain other motor disorders and spinal cord injury, all with increased motor function after having these pain stimulators placed. Okay, now these were both in pretty obscure journals. I think both of these journals are defunct now, and it wasn't really picked up. Okay, and then Susan Harkema, she has a large group in Louisville that's really done the most work on this. Let's see, play this, I hope this works. She started looking more specifically at epidural spinal cord stimulation to try to improve motor control after spinal cord injury. So the first video on top, first of all, this person who's lying on the mat, I believe was 27. He was 4 years after a motor complete spinal cord injury. He had already undergone every treatment possible, very intense physical rehabilitation, no effect. He could not move anything below the injury. Now he had an epidural stimulator placed. The stimulator is off in the top video.
Left ankle up, left ankle down.
Hopefully you can hear that.
Up.
Okay, so he's being asked to lift up his left leg, and these are just recording electrodes, by the way. The stimulator is in his back. Okay, these are just EMG electrodes recording his muscle activity. So now let's try to play the bottom one. Now the stimulator's on. Now, first of all, the stimulator's on for the entire video, but he's not moving during the entire video because the stimulator by itself does not move his leg. It's only when he needs to or tries to move that it happens. We'll start it over.
Left leg down, left leg up, left leg down.
Okay, so a few points here. One is that is not fully normal movement. Okay, if you don't have an injury, you could lift your leg much more quickly and smoothly than he can. That's the bad news. The ridiculous good news is this never, ever, ever, ever happens after a chronic motor complete spinal cord injury. You don't just suddenly regain years later the ability to move your whole leg. So something about this epidural spinal cord stimulator is allowing him to move or regain some movement ability in his leg under volitional control. And again, the stimulator is not just causing his muscles to twitch. It's stimulation plus volition. I think I'm going to explain more in the next slide. Okay, so this is kind of a schematic showing what is going on after you have a clinically complete spinal cord injury. You usually still do have some intact circuits, some electrical signal getting through the injury, but it may not be enough to reach that muscle's threshold to fire an action potential. Okay, so you're trying to move, you're not getting the threshold. Now you add the spinal cord stimulator and you turn it on. But notice it's on already here. There's no movement. There's no movement until you combine the epidural stimulation with the person's volition or intent to move. Now that combination gets you your threshold and your muscle fires. Okay, so it's very key to point out this is a sensory stimulus that is not moving you around like a puppet. It's giving you the ability to reach threshold at your own volition. And really the best analogy is it's a hearing aid for the spinal cord. We have very damaged circuitry after spinal cord injury, but there still is some intact circuitry. And with this epidural stimulation, you can now amplify the ability to respond to that little trickle of information that's getting through. Okay. So that is an example of the incredible, and by the way, this has been reproduced many, many times now at this point. The incredible motor improvements seen after epidural stimulation. But it's not just the motor nervous system. Something more up your alleys is autonomic nervous system restoration. This is orthostatic hypotension. Of course, my competitive juices get going when I see Dr. Berger. But this is usually from all the blood pressure meds or the prostate medications you're prescribing. But it can also be from spinal cord injury. Okay, so you get up, you get dizzy, and it's because the spinal cord injury is preventing that reflex constriction of the small or medium-sized arterioles and arteries in your legs from squeezing blood back up to your heart. Okay, so you get dizzy with upright position. And this can be very severe after spinal cord injury to the point where you can't even sit up without passing out. And it turns out people with epidural stimulators after spinal cord injury can have dramatic improvement of their autonomic functions. So this is before stimulation. At time 0, the person's head is put in the upright position, their heart rate goes up, their blood pressure goes down. So they're tilt positive, as you guys would know. And now this is immediately with the stimulator turned on in a blood pressure configuration. You now have almost a complete attenuation of that increased heart rate and decreased blood pressure. And this panel is even more impressive. This is after 80 sessions of epidural stimulation. Now the stimulator is off, but now you put the person in the upright position. You're comparing C to A here. Boom, their heart rate and blood pressure stay stable. They now can adapt to the change in head position that they couldn't do before. Okay, so epidural stimulation seems to be doing a lot to help both motor systems and autonomic systems. So Jill Weck, my colleague here at the VA and at Mount Sinai, she's an autonomic physiologist, and we're involved in a collaborative group with Susan Harkman's lab and others all around the New York area and Miami to try to basically implement this technology, still in the research phase, but try to get it going more widely. Okay, this is a pretty robust phenomenon we're seeing here. Okay, so very importantly, we don't actually have neurosurgery up here at the Bronx VA. So we need to know, can we do this non-invasively? Okay, can we do all the things we just talked about non-invasively? Unfortunately, the answer is yes. So that would be called, instead of epidural, it would be called transcutaneous spinal cord stimulation. And we have a lumbar stimulation program, but we're talking mostly today about cervical stimulation. So we're aiming at the circuits that lead to your arms and hand function. And there are a lot of groups doing this, but we take a pretty unique configuration of stimulating with the cathode or active electrode right over the lower neck or upper back and going directly through the spinal cord toward the front anode, basically over your thyroid cartilage. Okay, so and it's basically just little electrodes, just like you would see, a little bigger than an EKG electrode. You see here, when you send supra threshold pulses, you can trigger these movements in both arms, in both proximal, and the fingers are twitching as well. So proximal and distal myotomes of both arms can react to this type of stimulation. Okay, so potential advantages of non-invasive spinal cord stimulation are pretty obviously, it's non-invasive. You don't need surgery. Okay, and to implant a stimulator over the lumbar cord is one thing. There's plenty of space. It's actually quite easy to do surgically, but it's much more risky to implant a stimulator over your cervical cord where there's much less space to work with. Okay, so non-invasive is an advantage. And you saw those electrodes. All you need is long enough wires, and eventually we'll be doing this wirelessly. You can do it while you're moving around. You can stimulate both sides simultaneously. You can stimulate multiple levels of your arms, which are things that certain other types of stimulation can't do, which we didn't talk about. Now, one disadvantage of non-invasive spinal cord stimulation is it's non-invasive. Okay, so this is both an advantage and a disadvantage because absolutely we will never be able to stimulate quite as focally with as high enough resolution as you can when you're invasively stimulating the spinal cord or other parts of the nervous system. So it's going to be less focal by definition. Okay, and now we're talking about stimulating the neck. I believe we all know our ABCs. There are a lot of important structures in the neck. I just love the fact that, you know, I Googled these things and this came from a lawyer group. So we don't want to screw up any of these structures in the neck. Okay, so trachea, kind of important. The vagus nerve, we're extremely concerned about because that can alter autonomic regulation while we're stimulating over this area. And this doesn't even show the carotid arteries, for example. Okay, so there's many things we have to worry about when we're stimulating over the neck. So for that reason, we kind of stack the deck a little bit in our favor for safety. We exclude people who have certain risks of adverse events. But this is still a pretty broad inclusion and exclusion criteria. And we've done well more than 400 at this point sessions of this transcutaneous spinal cord stimulation without any serious events. And we're not really talking about ALS today, but we are doing this in people with ALS as well. Okay, and just to show you some results, again, let me start here. So I don't think I discussed TMS or transcranial magnetic stimulation yet, but that's a relatively about 30-year traditional way of stimulating motor circuits by magnetic pulses over the motor cortex, and you can induce a twitch in the contralateral hand if you're aiming at the hand part of the motor homunculus. Okay, so that's transcranial magnetic stimulation. The problem with TMS is that once you have a spinal cord injury, it becomes much harder to elicit muscle responses from TMS getting through the injury. It's doable, but it's harder. And we have found it's much easier to elicit muscle responses when we're stimulating with transcutaneous spinal cord stimulation. So first of all, 100% of participants have responses in their hands when we stimulate their necks with spinal cord stimulation. Only about 80-ish% have responses to TMS after spinal cord injury or ALS. So this graph actually underestimates the difference, but there's no difference between able-bodied spinal cord or ALS participants in their ability to activate the hands using spinal cord stimulation. And there's a big gap between able-bodied and the injured or diseased population in activating their hands using TMS. And again, this is an underestimate because it does not include those that don't respond at all to TMS. So we're saying, okay, this is a good way to access hand muscles when we can't trigger them using this magnet here. I'm not going to go through the details of this, but we've done experiments to show that transcutaneous spinal cord stimulation is activating dorsal sensory afferents. So afferent fibers coming into the spinal cord that then synapse onto motor neurons. So we're activating sensory afferents that transsynaptically activate motor neurons. And by the way, that's the same route that epidural spinal cord stimulation is working. And we already talked about the amazing effects that epidural spinal cord stimulation is having on various types of functions after spinal cord injury. So this approach is using the same route as epidural spinal cord stimulation. And so now we have a different way of trying to induce plasticity. So Alfie and I were co-interns with, no, we weren't co-interns with them, but this is Donald Hebb, or Hebbian plasticity. And the colloquial description of Hebbian plasticity is fire together, wire together, okay? So this is paraphrased in this quote. It's not his exact quote, but if axon A repeatedly takes part in firing neuron B, that will lead to increased efficiency of A firing B. So basically synaptic potentiation, okay? So this stands for upper motor neuron or cortical spinal tract. It stands for lower motor neuron. The way we move when we want to grab that cookie for dessert is our brain or upper motor neuron is telling our spinal cord or lower motor neuron to initiate the reaching process. So we want to strengthen that pathway. But I just told you, TMS, which is activating the upper motor neuron, does not always get through an injury. There's no injury shown here, but we may have difficulty activating this synapse from above. So now we have another window to get in here because sensory afferents come into the spinal cord at every level and they interact with the synapse between the upper and the lower motor neuron. So we now have another way of trying to get into this synapse and trying to take approaches that take advantage of Hebbian plasticity using spinal cord stimulation. Okay, so hold on a second. This floating window always gets in my way. Hold on. Okay, so can we use spinal cord stimulation to enhance that response to cortical stimulation or TMS? Remember, I said it's much harder to get a hand response to magnetic stimulation after you have an injury or when you have ALS. So can we use well-timed pulses of spinal cord stimulation to try to facilitate the response to TMS? And again, this is just a zoomed in schematic of what's going on here. We are now using TSCS to activate sensory afferents that feed into the synapse, and we're using TMS to activate the upper motor neuron that feeds into the synapse. Can we somehow find a combination of TMS and TSCS that strengthens this response? And the answer is yes, although it's taken years to get to this point. We had to try a whole variety of different relative timing and different intensities. But when we fire TMS, when we fire TMS over the hand area of the motor cortex and then deliver low intensity spinal cord stimulation at certain time points following the TMS, we can facilitate the hand response to TMS. So really what this is showing is that whenever the signal of the cortical stimulation arrives at the cervical spinal cord, either simultaneously with or slightly before the spinal cord stimulation, we get a big facilitation of the motor response. And it seems, by the way, their facilitation is more in spinal cord injury and as well as in ALS than it is in the people who don't have a lesion in their spinal cord. So we think we're just giving a relative boost to the people that have lesions in their spinal cord with this sensory electrical stimulation. And again, the time dependence of this phenomenon goes back to Hebb. It's A before B. So think of TMS as A, think of spinal cord stimulation as B. And again, this has taken a lot of work to get to this point, and I cannot thank our team enough for doing the work. Okay. So what I just showed you was the neurophysiological results of basically immediate pairing of brain and spinal cord stimulation. We're now finally funded and at the point where we can now apply repetitive stimulation of the brain or upper motor neuron along with the spinal cord via sensory afferents in a way that they meet or converge at the cervical spinal cord and try to strengthen circuits that go to the hands. Okay, so one way we're doing it is the way I just told you about, transcutaneous spinal cord stimulation. There's another type of stimulation that we're not really focusing on today. It's called direct current stimulation, also done over the neck, also modulating plasticity without actually causing the hands to twitch. And so we're taking both of these approaches in separate projects. And this is a collaboration. Again, Linda Murray is a younger investigator in our group, and we collaborate heavily with Jason Carmel, Jack Martin, and Jerome Dixon, all in the area. Okay, and these are a couple of other projects that I won't really talk as much about, but we also stimulate other parts of the nervous system. So we stimulate the lumbar spinal cord to try to facilitate walking. And this is a big collaboration with Dr. Maria Knickley's lab and a young investigator in her lab, Tim Pulverenti, where we combine spinal cord stimulation over the lumbar cord, where the leg circuits are, with treadmill training. And when you give weight-supported treadmill training, that's actually a huge sensory stimulus. Whether or not the person can feel it consciously doesn't matter. The sensory stimulus of your legs bearing weight, of your legs and joints flexing and extending, drives the spinal cord, and we're just trying to enhance that drive by adding electrical stimulation. So that's an ongoing project. And Linda is hopefully imminently going to be starting this project when it gets funded to repurpose all sorts of drugs that are already used for other purposes and to screen them for their ability to restore neuronal excitability after chronic spinal cord injury. So we have Parkinson's drugs, we have all sorts of mental health drugs, buspirone, atomoxetine, which is, I believe that's Strattera for ADHD. That has many theoretical mechanisms by which it should help for spinal cord injury. And pyridostigmine is used for myasthenia gravis. It's also used to poison people. So nerve gas is made of relatives of pyridostigmine. And riluzole is an ALS drug. Actually, that's being looked at for both acute and chronic spinal cord injury. So we're very excited about that project. And this is something I think many of you might be aware of, but believe it or not, goes against what Dr. Berger and I learned in med school, but restricting blood might be good for you. Restricting blood flow might be good for you. Okay, so you'll see people working out with these little bands on their arms. And actually there's a whole field of work that started in animals, but the biggest application right now is definitely in cardiology, where all you have to do is transiently restrict blood flow to one limb. You usually do 4 cycles, 5 minutes each of a blood pressure cuff, just restricting blood flow to your limb temporarily. That somehow seems to release circulating systemic factors that promote growth and reduce inflammation. And this seems to protect subsequent insults to your heart and other tissues. So it was found in rodents first, but there's a lot of clinical trials right now going on of giving people with acute MIs or people about to undergo heart surgery, giving them cycles of remote ischemic condition to see if their outcomes are better in terms of spared myocardial tissue. But this over here is a brain. I care about more about the spinal cord, but we also care about the brain, neurologists. So there is reason to believe that this approach might work for neuroplasticity, and Yuquan is applying this in a study right now to see if we can improve plasticity and hand function after spinal cord injury using this approach. Okay. So I definitely wanted to leave time, hopefully, for questions. So I want to kind of start wrapping up here with the dilemma I mentioned before. This approach to rehabilitation will absolutely require individualized therapy. There's not going to be a one-size-fits-all approach to improving function after spinal cord injury or TBI or stroke or chronic stroke, etc. You have to individualize therapy. So again, how do we find the best individualized long-term intervention? We're not going to have a magic bullet either. It's not going to be something where you go in to the neuro rehab lab and then that day leave with improved function. It's going to be a long-term intervention. But how do we know what the best individualized long-term intervention is? What we would like to do is run each individual through a whole gauntlet of very brief interventions, okay, and then use some of our tool bag to identify the best biomarkers to predict, okay, you just did one session of remote ischemic conditioning with certain parameters. Your EEG response will tell us that's the one for you, or it will tell us that's not the one for you. Let's come back tomorrow and try something else. So you just do one brief intervention after another. Use your screening tool bag to find the best predictive biomarkers that then say, okay, you need this therapy, you need that therapy. We don't have this yet, but we need to come up with this approach in a way to do it. We don't even, not only do we not have this, it's just anyone's guess what the best source of biomarkers will be. I am totally guessing, and I'm not an EEG expert, but I think EEG might be the way, might be the one that leads us to a certain biomarker, but we don't know what that is yet. My second choice would be serum. Okay. Okay, so again, just some take-home points, hopefully. Remember, it's not just about motor function or walking after spinal cord injury. And above all else, remember, spinal cord injury is usually incomplete. We have potential to improve function of spared circuits after spinal cord injury. And we take the approach, a lot of people take the approach of trying to reroute signals through that spare tissue, because regeneration is not happening today or tomorrow, I promise you that. And then activating the nervous system is how we increase neuroplasticity. We talked mostly about electrical and magnetic stimulation. We talked about Yukwang's project in remote ischemic conditioning and Linda's project using repurposed drugs. Again, I want to thank our coordinators, past and present. And this is a kind of more formal list of names up here at the VA and at Sinai and around New York and around the country. We have a lot of collaborations going on, always new opportunities coming up to collaborate in case people are interested here. This is another group. This is our intern class, or at least some of our intern class. I don't know, Dr. Berger, you've had a goatee for quite a while. How long have you had that goatee?
My children have never seen me without it.
Okay, well, I'll try to send, you can show them that slide. I also want to point out, we're at the VA, but it actually, very importantly, you do not need to be a veteran to participate in medical research here. So we have a lot of studies going on here. This is literally just a little snapshot, and there are other programs here in our center looking at other things. So if you have anyone with spinal cord injury or ALS who might be interested in research, you don't necessarily tell us directly, just give them this contact information, and I'm happy to send you a little slide or flyer if you want. And then they can contact us, and then we'll sort out, what they may or may not be eligible for. But you do not need to be a veteran to participate in medical research at the VA. So I think I'll leave that slide up, and hopefully there's some questions. I'm happy to discuss or try to answer any questions that are out there.
Thank you so much, Dr. Harel, for the amazing talk. Yeah, so we would love to have answers from audience.
Yeah, we can remind everyone to put it in the chat if you're somewhere you don't have video or audio, or feel free to speak up. To get things started, I have one comment, one question. First off, Dr. Harel, thank you for the amazing talk. I think the most important thing I learned and I'm going to take back is some people asked me the other day about because several movie stars, including one of the Helmsworth, whichever one is Thor, have been posting pictures of working out with all the bands on their arms, and people were asking about that. So now I know the answer, that it's actually a good thing, supposedly. Yes, that. And then my other question, which maybe, here in medicine, we deal with a little more the issue of orthostatic hypotension from spinal cord injuries, obviously an easy one, but we deal with the autonomic dysregulation all the time. And while you talked about it in terms of spinal cord injury, for some of these other diseases, Shea Drager and some of these other things related to Parkinson's, Are there other groups looking at the use of this sort of stimulation for those other diseases where we have orthostatic hypotension or other autonomic dysregulation type of things?
Yeah, so great question. So I haven't looked recently, but we were definitely wondering that exactly about what you just said. Some people with Parkinson's and Shy-Drager syndrome have terrible, terrible, terrible autonomic issues. And last time I checked was really actually a couple of years ago. And no, I have not noticed spinal cord stimulation for that, but we should look back into that. And I will discuss that with Dr. Weck, who's in the office next to me right after this. More things you just added to my inbox, Alfie.
Just trying to help. Just trying to help.
Dr. Harel, thank you so much for a great talk. I really enjoyed it and definitely felt like I learned a lot, as I did not have a lot of knowledge about this prior to this discussion, so I really appreciate it. One thing which I wanted to ask you maybe to elaborate a little bit more on was that you briefly mentioned how some previously FDA approved pharmaceuticals are being studied for repurposing for use in rehabilitation for patients with spinal cord injuries. That was particularly interesting to me, from a medical resources standpoint, from a high value care standpoint. So much of our patients' care can be limited by resource allocation and things like that. And it seems like potentially repurposing drugs that are currently being used may be a cost-effective way to provide care, maybe swiftly and hopefully effectively. How promising are these? How far are we away from these being a reality? Are they really just more of an adjunctive? Maybe just a little more information about that.
Great question. So this leads to actually another dilemma that wasn't even on that dilemma slide, but as far as this aspect goes, at what point do you have enough evidence to say, okay, we're going to do a trial of, let's say 8 weeks of levodopa for spinal cord injury? No one's going to fund that trial unless there's some evidence first. And so here's what Linda's run into so far. We have very sophisticated, which we didn't really discuss, but we have sophisticated measurement tools. So we're looking at neurophysiology. We can look at changes after 1 dose of each of these meds. Now, of course, 1 dose is not going to, quote, cure someone or even cause any lasting change in their clinical function. We want to generate evidence that 1 dose of some of these medications will change physiology in a way that we think predicts clinical response after repeated doses. And guess what? You submit a grant application on that, and people say, well, this isn't going to help anyone. But so it's like a catch-22. We need to generate some sort of preliminary evidence first. So I think that answered part of your question, but yeah, I would say actually there's very little out there. So Linda's done an extensive literature search. There's very little out there in chronic spinal cord injury. Most of the trials of drugs are in acute spinal cord injury. So we're talking about chronic spinal cord injury. There's some serotonergic drug, SSRI studies out there in chronic spinal cord injury, but really not much else is out there. So I do think, yes. Oh, sorry, that was a direct message. So the goal is to use these drugs in combination with other therapies, such as the exercise that's shown up here, or the electrical stimulation. It's going to take a multi-pronged approach, which is another dilemma. How do you get a multifaceted treatment proven and approved when you have to do each one at a time first? And for that, we need to look more at the cancer field, which obviously has all sorts of multi-drug regimens. We're way behind.
Thank you, Dr. Harel. Very interesting.
Thank you.
So as we residency program have a residency interview from 1 p.m. So maybe we can have only 1 or 2 questions before finishing up. Any other questions?
Just a quick point. So I kind of, there are two, this is more of a local blood flow restriction. It's a good picture. So I put, it's Alfie one who's an intern, but, it's local blood flow restriction. It's thought to work by kind of increasing lactic acid in the local area, and somehow that helps build muscle. I don't really know much about it. So this is meant to be more of a systemic thing, but it's a good picture, so I threw it in there.
All right.
So to clarify, so in your remote ischemic, you are actually, though, generating the ischemia to the limbs. It's not some sort of way that you're reducing blood flow to the spinal cord and then releasing it.
That's correct. We definitely are not trying to reduce blood flow to the spinal cord. It's one limb. It's very tolerable. And the blood has been collected, but it's not analyzed yet. It's going to be analyzed in a batch for all sorts of systemic inflammatory mediators and growth factors. And I can't even, I'm not as up on the field as Yukong is, but there is a lot going on in this approach in cardiology, a lot, to save myocardium.
All right. Yeah, thank you very much again, Dr. Harel, for this ground round talk. So yeah, I think we can wrap up the talk. All right, thank you so much.
Thanks so much, Dr. Harel. It
Pleasure.
was fascinating. All right.
Thank you guys for inviting me. Hope it's in person next time. We'll catch
Hopefully.
up, Dr. Berger.
Yes. We'll
Dr.
catch.
Bergers, I saw your dad on there at one point.
Yes, he joined in. All right. Thanks.
Thank you guys.
Thanks so
Happy
much.
holidays.
Yes.